Hemorrhagic shock is graded based on percentage blood loss and clinical compensation status. Class I loss is less than 15% or less than 10 milliliters per kilogram and is usually asymptomatic. Class II is 15 to 30% loss with tachycardia and cool extremities, but compensated circulation. Class III is 30 to 40% loss with hypotension, confusion, oliguria, and rising lactate. Class IV exceeds 40% blood loss with severe shock, cyanosis, and multi-organ dysfunction. Vital signs alone are unreliable until more than 25% blood loss occurs. Postural heart rate rise of 30 beats per minute or systolic drop of 20 mmHg suggests significant hypovolemia. Central venous pressure does not reliably reflect blood volume in acute bleeding. Lactate above 2 millimoles per liter indicates shock and tissue hypoperfusion. Hemoglobin and hematocrit are not reliable markers in acute hemorrhage. Fluid responsiveness is assessed using rapid fluid challenge or passive leg raise. A rise in stroke volume or cardiac output by at least 10% indicates fluid responsiveness. Passive leg raise transfers 150 to 750 milliliters of blood to central circulation. Stroke volume variation above 12% predicts fluid responsiveness in ventilated patients. Pulse pressure variation above 13% is also a strong predictor of fluid responsiveness. Rapid transfusion requires large-bore, short IV access to maximize flow rate. Red blood cells flow faster when diluted with saline, but not with ringer lactate due to citrate binding. Damage control resuscitation uses hypotensive targets with systolic pressure around 90 mmHg until bleeding is controlled. Massive transfusion follows balanced ratios of packed cells, plasma, and platelets to prevent coagulopathy. Reperfusion injury after resuscitation can trigger acute respiratory distress syndrome and multi-organ failure. Mortality increases with delayed lactate clearance beyond 24 hours and high transfusion requirements. Final takeaway is early recognition, controlled resuscitation, and rapid bleeding control to reduce mortality in hemorrhagic shock.